Afternoon, everyone. Welcome to UK. I am Dr. K. I'm a hospitalist, and 50% of my time, I'm a medical director of clinical documentation integrity, which is, hopefully you all are familiar with as fellows. It's a whole division here of people. There's about 30 plus nurses. And I also work closely with the coders to try to assure that we follow certain standards in our documentation and that a lot of bad things happen if the documentation isn't done properly. So that's what this is all about, better communication through documentation. After this session, you have a better understanding of the impact of good documentation and how we fail to communicate often. I'm sure this is a lot of stuff that you've seen before, stuff that you've done, stuff that I've done for sure. And then lastly, how we can do better. Objectives. This first part is more, I give this to the interns as well. I'm going to just breeze through this first part of the primary goal of our documents and the format for an effective assessment, assuming that you are going to be more supervising as opposed to writing notes, but it's still good stuff if you want to look back at it. It's stuff that you need to teach your interns. So the second half, which is actually going to be more than half, is the secondary, more sophisticated goal of the written record, namely the creation of research quality databases and the standard nomenclature that we need to create quality databases. So my background quickly, I trained at Grady, at Emory University, mostly at Grady, felt like, during the AIDS pandemic in the late 90s. Which was quite an experience. Then I went up to Detroit, went home, worked as a private for a very short time before I quit because it was terrible, and moved to Hawaii. They gave me a Jeep and I commuted. This is the H3 every day in my commute through this mountain. They need doctors if you are so inclined. Then I moved back to Detroit. It's where family is. I was associate program director for the residency at Wayne State, and I worked with the hospital as well. That's when I started to learn a lot about how what we document holds up care and makes all of our lives more difficult, patients and caregivers. I was recruited down the street to Henry Ford, did a lot of the same there. And then my mentor from Emory was moving from Northwestern to UK. So he asked me to come with him. And that was about 10, 11 years ago. So every place I've worked, there's not really much guidance on how they want your assessment created and structured. Hawaii was the only one that really provided me any sort of guidance, and they focused a lot on goals of care as one of the problems, which is really actually pretty refreshing. They would come to you if they saw you didn't have a goals of care in your assessment. So it looks like this is very similar to last year. 2/3 of you have had some instruction on how to construct a good assessment. That's good. Your interns are 50-50. And it's really, I'm talking about just the assessment, not creating a SOAP note, but really what goes in an assessment. And you're going to see a lot of what we're coming up on. This is the basic goal. You don't want to look like these two guys, you know that, especially code teams, rapid response and night coverage. They're coming and they have the electronic record. That's all they have. They don't have you to give them a warm handoff as a patient is crashing. So very important that we get things right. If you have a nurse looking like that, you're going to have a family member probably looking like that. That's a lot of time and an effort going back to the room, trying to explain things. So that what you write helps make your life and the life of your patients a lot easier. This just came out last month, so it's interesting about communication type and quality on outcomes. And if you've ever been part of a Sentinel event, hopefully you have not, but everyone gathers if something bad happens that wasn't expected. Almost everyone that I've been a part of, has been related to communication. This systematic review showed that 60% were related to poor communication of various sorts. And obviously misdiagnosis, life-threatening complications, suboptimal treatments, all stem from miscommunication often. So this is what I advise the interns to do. Detroit format, I developed this at Henry Ford with a lot of input from interns and residents and fellows and staff. We really tried to distill it down to the most simple aspects of an assessment. And you can read that. So diagnosis, the etiology of that diagnosis, how you're treating that etiology and how they're responding to your care. Some examples quickly. This is just from last month, 2 months ago now. This patient, if you came running to the bedside and they were decompensating, this HMP has acute ischemic right MCA. That's actually not why they're there. That was the previous admission on the 15th. So there's a lot of copy and pasting. They had some blood loss from the catheterization site. So they're actually here at this point for an assessment for a possible stent extension or reinforcement. You do a lot of reading before you get to that point. So obviously I call those the Where's Waldo notes, because you end up having to pick out the good stuff here and there. So you're going to see it, tell your interns not to do it. Try to help them distill things, process the data. Another case, you can get so succinct that you lose a lot of important details. This volume populates this ICH score. ICH is nebulous term, as you'll see from the results of that survey. So left frontal hemorrhage, where is it? Subarachnoid, subdural, mechanism. It's great that it's mentioned, but it would be nice to know, does everyone get platelets when they have an intracranial bleed? Everyone on a drip? So acuity as well, it's very important. This patient, when they come back in a month or two, encephalopathic again, they're going to have the evidence of that intraparenchymal bleed from the review of the chart. It's going to be there. They don't all require admissions. So it's important to state that it's acute. Nothing can be assumed when you're creating that research and quality database, and definitely nothing can be assumed when you're taking care of the patient and when they're responding in the middle of the night. So there's no secondary diagnosis to explain what you're doing here as far as giving platelets and placing the patient on a drip. So assessment, I tell the interns, you're making a judgment. You're not just reiterating data. You're giving your opinion on the data that you've collected. So for this one, if you stick it in the Detroit structure, that I would say acute encephalopathy due to acute left frontal intraparenchymal hemorrhage. Very specific. They're going to know exactly when anyone comes to that chart, they're going to know what's going on. Etiologies, that's why they're on the drip, because of the malignant hypertension. This is very important if you ever want to do research and it has anything to do with anticoagulation. If we don't write that the patient has an fill in the blank drug induced hemorrhagic disorder, it's not going to register in the chart as an adverse effect of that drug. So just know that. Not something I was ever taught. I actually figured that out reviewing cases and saw people, obviously you have delays of care, you're not doing procedures, you have extended lengths of stay, higher risks of mortality. But if you don't state that they have a hemorrhagic disorder due to that drug, it doesn't exist. So, and that's the, let's see if I can move. Okay. Yeah, responsive therapy. You're going to see this a lot too. Diagnostic criteria for sepsis in the assessment. They don't need to do that. Digest all this stuff. My middle schooler could say chest x-ray with no infiltrates when they read the computer, right? When you're looking at Epic, you want to interpret that, make a judgment call, give your opinion. The septic shock, all that green can be just summarized like that. Presumed descending cholangitis. This means no HCAP as the source of the sepsis. This means no septicemia as a source, right? So you get the point. Have them process it. And I force myself into this structure all the time. It helps me when I assume care of a patient who's already been admitted. It saves me a lot of time, saves me a lot of hassle. If you don't have the diagnosis, you only have a symptom or a sign, this is what I tell them to do. State the symptom and then your differential, possible etiology, how you're treating it, and what you're doing to test to see if it's there or not. Again, possible unstable angina, how you're treating it, how you're analyzing it, testing for it. Okay, this is what I tell the interns. Don't use versus. If you use versus, then you force the people who are creating the code for our research and quality databases to choose one. You don't want them to just, we have a lot of multifactorial here. So don't use versus. Now the second half, Hopefully that was quick, because I'd rather spend more time on this with all of you. This is the more sophisticated goal of the medical record. So obviously we are making a database. I assume you are, almost all of you, interested in research. Like you've heard over and over, garbage in, garbage out, right? So you have to have a good database if you want to be able to pull off good research. This communicates severity of illness and risk of mortality to our quality database, helps the payers understand why we have a patient in the hospital. And everything that we write, it determines the weight of each case, and that determines staffing. So we determine how much staff we have to help us take care of patients based on what we write. Public profile is also important. We've been hanging the shingle, the best regional hospital, out since 2016-17 every year. It's based on what we are, how we are documenting. Patients can compare us to other hospitals. Lots of websites out there where they can compare. So this is a point that is lost on lots of attendings that I work with. No slight on them. This is not something that we learn about. So when you document, your note is creating two separate codes. ICD-10 codes, which you have hopefully heard about. Those generate fees for the facility. Evaluation and management codes generate what we call professional fees. RVUs around here, work units. I'm not sure exactly what that. I don't deal with this part at all on the right. So we're talking completely about the ICD-10 codes. And that's what creates our research and quality metrics. These set of codes describe how sick your patient is. These describe how hard you're working. This is an antiquated, the E&M codes are an antiquated system based on when we had private docs in the hospital. So the docs, you've heard the term, you eat what you kill, right? So they would describe what they're doing. We had a lot more that we had to document back then, however many review of systems and exam findings and all of that. So thankfully we don't have to do that anymore. But there are requirements that someone, I assume at some point, they're gonna talk to you about the E&M codes, and that's not my realm though. I deal 100% in the ICD-10 realm. So always important to reemphasize communication between all of us as professionals. That's the primary focus. That's the vast majority of what we're doing. Just understand that behind the scenes, we have a lot of people that are combing through every single one of our charts, not just the summaries, not just the H&Ps. So they look at everything and they extract the code. And if you follow that Detroit structure, you're going to satisfy both vast majority of the time, and you're not going to be contacted by them to try to help clarify. In general, the D and the E of Detroit populate the ICD-10 codes, and the E&M codes are created by the treatment that you're administering and the response to the treatment. That's a reflection of how difficult things are for you to get your job done. So that's in general. There's some overlap, but that's a breakdown of the codes. So if you, like I say, if you understand that, I get questions about this from attendings all the time. So not as many of you were told that we have one of the highest expected risks of mortality. That's probably because we are no longer in the top 1 or 2 like we were for years. We're still very high. And that is in tune with all of this, the quality metrics that I've been talking about. Probably the most important quality metric, the one that I consider second most important. The most important is going to be the observed mortality. Second is expected risk of mortality. So when the patient walks in the door, before we do anything with them, to them, what is their risk of death? And that's typically based on not just acute issues, but all the chronic stuff that you think might not be related to what you're doing. We voluntarily contribute our data to this group that used to be called the University Health System Consortium. They were bought by Vizient. So you're going to hear people talking about Vizient metrics. That means quality metrics. 101 institutions in our cohort, 600 beds or more, academic medical centers that do transplants. That's our cohort. Just a small sampling here. This is typical of probably one of the most impactful charts that I review on a regular basis. It's ranked by expected risk of mortality. As you can see, we're at the top. We have the highest volume in the top as well. So 5.44% of the patients walking in the door who are getting admitted are expected to die while in the hospital. 4% did. Index is simply observed over expected. So you're gonna see this thrown around. We're always striving to drive our expected down as far as we can. And I'll show you some examples of where we were. So this is 2020. You all lived through 2020. So there's the first COVID spike. Oh no, I didn't do that. I split these up. Okay, so I'll just give you the background on this one. There's some more slides coming up in a minute. This is where we typically lived from 2015 until 2020 when COVID hit. Top 5 every month. Because we were top 5 every single month at the end of the fiscal year, which is the end of June right now, we were typically ranked number 1 in our cohort of 101 academic medical centers for expectation of death for the patients who are walking in the door. Very sick patients. As you go on to apply for jobs anywhere, you could ask for this data. We're happy to give it to you. A lot of people say they train in places where patients are sick. Not many places compare to UK. And that's speaking from experience too. I think only the, bless you, quaternary care Emory Hospital in Decatur, Georgia, compared to UK. And they have their patients are coming in from the hills. Their patients have support networks and a dense city of Atlanta around them. So you can see what happened. We'll go through this more in a couple slides. So what's this based on? All these codes are based on the International Classification of Diseases. That's where ICD comes from. Long history of it. Started the first international meeting to discuss the ICD codes was in 1900. This guy was here is the guy who created it. Statistician, physician, wore all sorts of hats. So important to understand that this is us. These are physicians that create ICD-10 codes. A lot of docs don't like to talk about this stuff. They get upset about it. They think it's a money grab, which we are one of the few countries that use ICD-10 codes to gauge reimbursement in the world. So very few countries use codes that way. But keep in mind, this is our nomenclature. These are all our professional societies that create these codes. So you can see 1990 is when ICD-10 came out and was accepted, endorsed by the World Health Assembly. 1994, the World Health Organization member states adopted it. Took us until 2015. You can see the explosion in codes. Much more robust, much more well-defined database now for us, but we had to determine through experience how to reimburse according to these codes. I assume that's probably a big chunk of why it took so long to adopt it. So we need to speak the same language. We can't call a diagnosis something in California and something different in Michigan and a third thing in Texas and hope that we can pull off some high quality research or even compare ourselves to each other. So this is just something as simple as soft drinks, right? So something important like ICH is a nebulous term in the research, in the literature and textbooks. Well, I forget which one. It's either intracranial in the textbooks and intracerebral more clinically, but the problem is there's no consistency between research and textbooks and clinical, and therefore the term has really never represented anything specific. So really don't use it. We have intraparenchymal hemorrhage, we have IPH, SAH for subarachnoid, SDH for subdural. Be more specific. This one is unfortunately a nebulous term, and you're going to see it. When you see it, fix it. It's more specific. If you ever want to do research based on bleeding, based on neurologic, neurosurgical complications, whatever, it's important. Your research is going to be more difficult to pull off. You're going to have to do a lot more chart reviews if your database is not specific. So you can see the COVID spike. Back to this chart. This is our expected risk of mortality compared to our cohort. So like I said, we lived up here forever, took that for granted. And COVID hit, even though we dropped and our expectation of risk of mortality, meaning our documentation was suffering because we were suffering. Even after that dip, we still, at the end of that fiscal year, were ranked #1. Here you can see we had the second COVID spike. We handled it better, a little more experience with it. We drop here, right in the lull between this one and this massive double-headed monster that hit us, that also we experienced drops there. So what did we do here? This is when we decided to go live with Epic, which was wonderful. Right between these two massive spikes. So you can see after we went live with Epic, it's a great depiction. It's a great depiction of how documentation has affected our quality metrics, our expected risk of mortality. Never again have we cracked the top 5 except for this month right here. So you can see, as even after averaging, we took a dip here, we're #6 at the end of this fiscal year here, 14 now. We don't have the data for this year yet, but interested to see what happens. So what changed with Epic? Problem lists were not really used in SCM, our prior electronic medical record. So what I've been told over and over working here is that problem lists are not in the culture of UK, which is interesting. So there's an out-of-box Epic functionality that uses problem lists, and it's actually going live soon because we're hoping that it's going to help with this problem. And hoping that it'll change the culture, because a lot of the culture is dictated by the interns and residents who are, they're doing the vast majority of our documentation, and you're coming from other places. So I'm hopeful. This is a patient that I took care of. Now in the new system, because the coders can see that we alter this problem list and it's imported into our discharge summary. This patient came with sciatica. After 4 days, I think an MRI was done. Nothing acute was found, and we saw an acute sacral fracture. So because that was not changed to the principal diagnosis, and there were 1, 2, 3, 4, 5 reasons to have pain out of this problem list, the coders discharged that patient with the principal diagnosis of sciatica. So that includes, so you're in a group of all the patients in the whole United States who have been admitted with sciatica. That's your expected risk of mortality. So you can imagine that expected risk of mortality is going to be very low compared to the cohort of patients that are admitted for an acute sacral fracture. So that's part of the problem, is that we're not really judicious about our problem lists. Another is we think that because Epic is fancy and new, when the interns go to do their discharges, they go to the discharge tab, they start working their way down the work list here. You click create note. The only text in that note is going to be coming from this hospital course tab, which is sometimes completely empty. So you have to be careful. Yet this is not typically structured. This is going to be a Where's Waldo type of text for the PCP for an outside ER that doesn't have access to our Epic. And it's not going to be really enlightening for the next team that admits the patient. You have to see too, I can't see the bottom corner of my lip, but if I were to create this discharge summary right now, the date I'm discharging the patient is late October. Last time that was edited was early September. So a lot of people are clicking on that, assuming it's populating something worthwhile, and often it is not. So also, I've been in your shoes. I've had patients die, obviously. When your patient's dead, you don't take as much time to document. You want to get on to take care of someone who needs your help, right? So same with hospice transfers. You give a warm transfer to hospice. You assume that admission to an inpatient hospice bed is going to be their last admission. So you're not taking a lot of time to put details in your discharge summary. The problem is that that discharge summary sets the expected risk of mortality. So if you leave it practically empty, the patient looks like a healthy patient went to hospice, or a healthy patient died. So be careful with that. So the solution for those two, what I tell people is you take any good assessment plan that was recent, copy and paste it and put it in the discharge summary. Even if it's not up to date, even if you don't change the little things like we're going to follow this lab every day. I mean, that's style points, but it's so much better to communicate to the next level of care, or to communicate, in the case of death, the expected risk of mortality of that patient. It's very important. For the problem list, a lot of people still print their problem lists and they round with them. You'll see your interns carrying around paper. You might do it yourself, probably because Epic doesn't really allow for an interactive problem list electronically the way it's not as useful. So look at that problem list that's auto-populated into your or your intern's rounding list. If it doesn't make sense, just make it make sense. You don't have to dig into that problem list and reinvent the wheel. But take a look at the reason for admission, which is on that printed problem or that printed rounding list. And yeah, I mean, I could give you so many examples. Patients admitted with like multiple traumas, and it has debility or obesity as the principal. It gets to be a problem. That's how we get patients going home with symptoms and lab abnormalities as their principal diagnosis. So examples. This is also one of my patients admitted. So when end-stage renal disease patients are admitted, say then they've missed hemodialysis and they're hypovolemic, they end up in what's called a DRG, a diagnosis-related group. All the patients around the country, around the world, who are admitted for this problem and land in one DRG. So for our cohort, on our calculator, each DRG has a calculator. It's an Excel file, and it has all these secondary diagnoses that have been found to increase the expectation of mortality in the past year. So in general, this patient population, the expected risk of mortality is 1.3%. Now, because when the patient was admitted, I documented they were in shock, they had malnutrition, and they were thrombocytopenic. Even though it had nothing, I mean, the shock was obviously something we were dealing with. The malnutrition and the thrombocytopenia were not acute, but I wrote them down. And her EROM adjusted to 19% from 1.3. Then I got this query from CDI. I was working with them at the time, and it annoyed me. Believe me, I'm not the only person that gets annoyed by these. I thought to myself, why are they asking me if this is acute or chronic Hep C? Acute Hep C is nothing clinically, almost all the time. Obviously, the patient has ascites. Can't they see that in the chart? Well, they can't. They can never assume anything. You have to write explicitly what things are. They can't put the pieces together for us. There's other reasons people have ascites. So what they are asking you is, what kind of liver are we expecting? Because you have a big difference in the expected risk of mortality between these two livers. So be nice to them. Don't shoot the messenger. They work with us. They're trying to help us. Believe me. And this is what happens, right? These are the actual numbers from that case. Absolutely ridiculous ballooning of the expectation of mortality in that patient to almost 50%. So that's what our documentation does. So be careful, be specific. Know that this is what populates our codes. Things that we write, nurse practitioners, social determinants of health like homelessness, believe it or not, like arguing, like contentious relationship with your in-laws is actually increasing. It's like a quality metric. So it impacts outcomes. Sorry, I can believe that. Anyway, so understand, so that stuff, sorry, sidetracked. This is what, when you give me a little extra time, this is what happens. Social determinants of health can be documented by case managers and social workers, and they can pull that. So understand that. All of these, if the person didn't, like reports, if the person who's making that report didn't see the patient, they can't extract a code. Except nursing, they can't extract codes from that. Pathologists, if a pathologist comes to the bedside and does a biopsy and writes a note, like a SOAP note, they can code from that. PTOT notes, these you have to process. You have to take that data and you have to bring it into the current episode of care and talk about how it's significant in your HPI or whatever. So stay away from slang and be precise. Soft blood pressure, if you want to do research on hypotension after cardiac cath, after, whatever the case may be, if people are calling your patient's soft blood pressure instead of relative hypotension, and the person who's typically on 4 drugs, and now they're all held, and they're 110 over 70, you have to document that's relative hypotension. Mass effect, that previous example, they're going to have a mass effect from that bleed for a long time. The edema suggests that it's acute. Okay, subtle stuff like this. COPD on home O2, people go home on O2 after, say, thoracic procedures all the time. Do they have chronic hypoxic respiratory failure? There's a difference between the two, obviously. Transaminitis is a lab abnormality. You take too much Tylenol, well, no, that's a toxic hepatitis. Call it a hepatitis. Whether it's toxic, whether it's viral, whatever. Congestive hepatopathy, transaminitis means nothing. Means that the labs are abnormal. Chronic, I see this a lot on the cardiology services because they tend to cohort a lot of the CHF cases. Chronic CHF is copy pasted. And if the patient eventually becomes hypervolemic, someone will write this with volume overload giving Lasix. That's still chronic CHF. This has a much lower expected risk of mortality than acute CHF. So be careful. AMS is about as nonspecific as it gets. Okay, so that's drowsiness all the way to coma. Encephalopathy is the diffuse axonal dysfunction that you see on an EEG that manifests as an altered mental status. Lots of different etiologies. All of these have acute and chronic manifestations. So be specific. If you have a patient going for a procedure and they're encephalopathic and they're over 65, 30 to 40% of them are dead in a year. If you don't write that that patient was encephalopathic after their procedure, then they die, they look like they are healthier, right? They look like they shouldn't have. Doesn't look like 30 to 40% of the patients in that cohort should have died if you don't write it. So a lot of people say, oh, they're sleepy. Yeah, there's a certain amount of time you're going to be sleepy after. It's still encephalopathy. You're going to be encephalopathic after anesthesia. But if that persists, hyperkinetic, hypokinetic, whatever it is, it behooves you to write it. That changes our expectations of mortality. I don't recommend stacking hashtags. If you can link them, that's good. This is a patient I saw. They had a repair. Everyone had to dig into the chart to see which one of these two was repaired, the hernia or the fistula. This is a patient I inherited. A lab abnormality and a symptom were elevated to the assessment plan title. I don't know why. My guess is that they got vomited on, is what it is. And that impressed them so much they put it up there. So what happened was the patient had hepatitis, acute hepatitis from reactivation of Hep B on a chronic Hep C, and they decompensated their cirrhosis. That helps everyone, not just the databases. It helps anyone who comes to that bedside understand what's going on. So link your diagnoses, paint a good picture of your patients. Don't make others do that in the middle of the night. Really popular one now, ISO, in the setting of. So in the setting of increased ice cream sales, there's more shark attacks, right? So understand that. In the setting of is only in a correlation. There's no causation implied there. If you ever write a sentence like this, there's no cause and effect. There's no relationship between these two. If you can kill this in your interns, I do this all the time. And it's so ingrained, I don't know why, but eliminate it and everything will start looking better. Get to the root cause of problems. If your wound is not healing, what's it due to? Right? Atherosclerosis, poorly controlled diabetes, whatever it may be. And then set up a plan to treat both of those. If not, it's your care, it's your technique. It's a hospital acquired problem if it's not due to one of their comorbidities. You see this a lot. Make sure you state what's causing the volume overload. Get the etiology in there. I see a lot more cirrhosis than I do nephrosis or CHF. Both these people are bacteremic. Bacteremia means very, very little. Doesn't demonstrate any severity of illness. Septicemia and sepsis does. Both of these are cellulitis. If you don't state that it's limb or life threatening and describe how extensive it is, guess what the payer is going to pay for? And guess what the quality metric is going to show? It's not, yeah, it's just not going to appear significant. You pull a sheet back, you're looking at someone's extremities, you see a toe's missing. If he ran over the toe with his lawnmower, he doesn't have an expected risk of mortality. If he has atherosclerosis, he's a very different patient. When a team tells me they have a patient with an amputation from atherosclerosis, everything changes in my head. The whole concept of what physiologically that patient changes. Don't use these two terms. Even talk to the vascular surgeons, they agree. These are non-specific. Atherosclerosis is only one of the etiologies of PAD. Happens to be the most significant. You have to write that though. And it's not as bad as back when we had to write. You can just copy and paste these forward. There's your PVD. There's just a little sampling. Okay. So if it's atherosclerosis, say it. Same with cardiomyopathy. You can say guys had 10 stents, CABG, EF is down, regional wall motion abnormalities. If you don't state that the patient has ischemic cardiomyopathy, it doesn't exist. And that is a higher expected risk of mortality. Post-op respiratory failure. Lots of different reasons why people stay on the vent. Some it's just normal, right? They're going to be on the vent for a while after a procedure. Some is due to an underlying process. You have to state that. If you don't state that the patient continues on the ventilator because of some other process, that's a PSI. That's a patient safety indicator. It's something that's tracked. So it behooves us to explain why someone is on the vent longer than expected. Otherwise, it's a complication. You'll see this a lot. You're in Kentucky now, if you weren't before. Tobacco use disorder. Obviously, this guy has a longer length of stay because he's living part of his time outside the hospital. Believe it or not, they both have an extended, increased expected risk of mortality, depending on why they're admitted. But that changes our quality metrics. So don't make your patients look healthier than they are. Paint a good picture. Don't use signs or symptoms. And suspected is in red here because your suspected diagnoses mean a lot. It means a lot to the person coming to the bedside. If it gets to the discharge summary, if you say suspected whatever for 30 days, and you don't put that in the discharge summary, it's not coded because they assume that you no longer suspect it. Slang, stay away from it. If you'd be embarrassed to see it, to have your patient see it or to have it displayed in a courtroom, don't write it. Suspect, once again. It's going to help everybody if you write down what you suspect. Link cause and effect. Acuity is very important. If there's differences of opinion in the chart, call them out. Talk about the discussions you had with the other service. If you didn't have a discussion with the other service, you should. That's quality metrics. Obviously, if you have a system where patients aren't, or the teams aren't talking to each other, there's obviously going to be lower quality care. Subcategorize things when you can. So remember, better documentation, improves communication, a lot less hassle for you, easier life for you, better care, better research and quality metrics. So since last year was the first year that when we picked up on this trend, and I told the incoming interns and fellows, we have not dropped out of the top 15 since that. Now that might be ice cream sales and sharks, or who knows, it could be cause and effect, but see what you can do. We'll see next year what kind of metrics we have, but that's the story. Focus on communicating with each other. Don't write Where's Waldo notes. Don't let your interns do it. Have them. It takes a lot more. It's that old adage that I can't remember who wrote that. Sorry, I wrote such a long letter. I didn't have time to write a short one. Right? I can't remember who said that, but digest. Use that format. Highly recommend it. Remember the databases. Paint a good picture, even in people who are dying or dead. All right, and that's it. And reach out to me. Like I said, there's lots of misconceptions. I have attendings coming to me all the time. I present to everyone pretty much about this stuff. So
we have a few questions for you. I'm just gonna pull my laptop over.
That's good.
There's some alphabet soup in there that my non-clinical self is gonna have a difficult time reading.
Okay, cool. Oh, I like it. Yes, so the decrease in expected risk of mortality reflects a less robust documentation for sure. Yep. Yes, suboptimal use of Epic, and also you can see we dropped, so our expected risk of mortality ranking dropped that month, but we really did okay in the end, right? Because month by month, we were still consistent. I would assume that when something national hits, like COVID, everyone's affected, right? So everyone's quality metrics were affected for that. But yeah, suboptimal use of Epic for sure. And this is why, so we're gonna have this, there's problem-based charting. If you've used Epic before, I used it at Henry Ford and we had problem-based charting. And if you're familiar with that, you know that, say, if you're constructing the discharge summary and you are managing a problem like renal failure, you can see everyone's note who's used that problem. And you can pull their data into your problem, or into your problem for your discharge summary. So I'm hoping that that culture takes over. It's foundational Epic, and I don't know, well, I know why we didn't do it, but I think it was a bad decision. Acute on chronic heart failure matter when it comes to expected risk of mortality. It does. Acute is going to, so to understand, expected risk of mortality is calculated on the day they come in to the hospital. So acute on chronic is going to have a different expected risk of mortality in some diagnoses. Now, it also increases reimbursement. I don't really talk much about that, but if you don't have acute CHF on admission, when your expected risk of mortality is set, and you develop it on day 10, the expected risk of mortality doesn't change, but the case weight changes and you get reimbursed more. That's a little more in depth than I typically get. Hopefully that made sense. Distinction between types. At this point, no, there is no distinction between types of heart failure when it comes to calculating. These are good questions. Next year, I can actually bring, I can have a slide that has the actual calculator for a common DRG like sepsis. And CHF is a variable that impacts expected risk of mortality. There is that long list of etiologies of CHF, HFpEF, HFrEF, HF improved EF, all that stuff, all feed into that quality metric. So if it's present on admission, it impacts the expected risk of mortality the same. In the future, as this database gets more granular, that might change. But as of right now, and it changes every year, as of right now, that's the way it stands. All of those different types of heart failure are going to impact expected risk of mortality exactly the same. Is there a linking word not in setting of that captures attributing factors that are not strictly causal? I stick with due to. I mean, I think, and there's so many that actually satisfy it. Like you can say suspected due to, or likely due to, or if you're not confident enough to state due to definitively, all of those other adverbs.
Mm-hmm.
Yeah. Oh, yes.
Likely.
Yeah. Okay. So all of those adverbs will all, the due to is the important part. So that establishes the link, if that makes sense. If not, just ask the question differently, but I think I answered that one. Uncertain of the etiology of lab abnormalities, label as problems such as. Sure, yeah, you can do transaminitis of uncertain etiology is fine. That's still going to register as a lab abnormality. So that's if you have no suspicion. I mean, if you don't have any suspicion, that's fine, yeah. But you technically, because you're doing any workup, that workup is because of a suspicion. So you're waiting for labs to come back. By the way, there's an order set, abnormal. If you just type in abnormal in Epic, it'll come up. Abnormal transaminases, I think is what it is. And it gives you a whole, it outlines the whole approach to acute transaminitis, as much as I hate saying that word, acute hepatitis, immunocompromised, what labs to draw more than 6 months. Yeah, so that saves a lot of time. But yeah, I would think that if you're doing any sort of workup, you have a suspicion. So it's okay to say uncertain etiology, but the people who are coming in the middle of the night are going to want to see, they'd love to know what you're thinking, what you're suspecting. So, okay, great. I'm glad, Pat. Glad that answered it. Cool. All right.
Questions?
Yeah, good stuff. All right, like I said, yeah, don't be shy about that email. Just go ahead and use it if you have a question. Thanks a lot. Good luck out there.